So the next topic is a discussion debate, MIS versus open TLIF. And if I could have the two debaters up here, I hope this is going to be a friendly debate, hopefully as exciting as our current debate, whether we need a border wall on our southern border. But with that said, very quickly, as we're getting up, this is a typical case that we all see in practice. 65-year-old female, progression of her back pain and new onset bilateral L5 radiculopathy. You can see pretty high-grade spondylolisthesis with collapse at what we're going to call the L5S1 segment, the lowest motion segment. You can see with flexion extension, she does move a little bit, but really her disease is facet-based. So if you look at her parasagittal, she has severe foraminal stenosis, and she's got facet arthropathy, synovitis. So this is certainly a case that I think many of us in the room would say a posteriorly based procedure is a good procedure. And really the question is, in the hands of the two surgeons up here, which would be a better option, an open posteriorly based TLIF or an MIS TLIF. So we're going to get to that in a minute. I do have a question for the audience. Of those of you that are doing TLIFs, who are currently doing open TLIFs? Show of hands. And who are currently doing MIS TLIFs? So it's just about 50-50. So this is going to be an exciting debate. So with that said, if we could have Charla go first, because she's talking about the options that this patient would have for an MIS procedure.
Sure. So I can just sort of click through. Okay. So real quickly, who here came by horse and buggy? And who came by an airplane? No, I'm just kidding. So a lot of this was already talked about by our previous speakers. So in the interest of time, I'm going to go to the study showing that initially we were looking at equivalence, making sure that MIS versus open have the same fusion rates and no worse complications. And that was definitely shown. And then comparing pain scores, the MIS fusion patients or the MIS TLIF patients on the forest plot definitely had better pain scores. And complication rates tended towards better or less with the MIS techniques. So there's a lot of studies and a lot of meta-analyses showing superiority of MIS TLIF versus open as far as lower blood loss, shorter length of stay, shorter pain scores, equivalent fusion rates. And then at NYU, we did our own review, and we found that for the MIS patients versus the open, the blood loss was significantly less with the MIS patients, which I think is one of the major key issues. If you can have less blood loss, then patients feel less crappy afterwards, and they're able to mobilize a little faster. It's a less of a hit to the system. And you can see shorter time to extubation, and then the hospital length of stay was significantly shorter. So, I mean, this is really just going over the technique a little bit, but this is really my key point is that within our own institution, people doing open versus MIS, the MIS patients just got out of the hospital 2 days faster. And I think that's really important.
So would there be a time that you would consider not doing an MIS procedure at this point in your career? Are there any contraindications to MIS procedures?
You know, I think it's the MIS TLIF, MAS PLIF, lateral, ALIF, and perc screws. They're all just the tools in your toolbox. So you want to first identify what the patient needs. Do they need a fusion? Do they need disc height restoration? Do they need decompression? Is it a foraminal stenosis? Is it a central stenosis? And then from there, you can determine what would be best for the patient. So mostly, there are very few cases where I think an open TLIF is preferred, definitely in deformity cases and things like that. If they've had a prior minimally invasive decompression and you're worried that you're going to be running into scar tissue or things like that, I might consider open, but for a 1 or 2 level, I'm going to go minimally invasive every time.
And the other thing is infections are negligible.
Yeah.
Knock on wood, I'm not seeing ones to MIS.
So speaking of that, Justin, you're up.
All right.
Let's see the slides if you can.
You can just cut out of my.
Thought this was going to be more of a debate. Let's go back to the beginning here. All right. So I'm here to argue that open TLIF is the gold standard. And here's my opponent. So we know that Charla in her early career has had numerous grants and an incredible CV. She's an editor of JBJS. She poses nice for the camera. In fact, there's so many pictures on Google Images on Charla. This was actually the worst picture that I could find. So I'm glad she didn't have any pictures of me. There's some bad ones out there. And seriously, she's an expert on MIS. She's gotten some great grants, an RAF grant. But in one of the interviews that she had, she was asked about why did she decide on a career in medicine. And her father's an anesthesiologist, so she wanted to combine a career that she could be in the operating room but also seeing patients. And one of the things that she also mentioned was how much she loves complexity and challenges. In fact, taking the most complex and making it even more complicated is something that she's been known for. But before we kind of get into that, we got to go back to the goals of surgery. We need to have a thorough decompression. I think there's no debate that the adequacy and the improvement in patients is based on how well we do our decompression. That's what drives our outcomes. The stabilization prevents further progression of the disease, especially at that level. And then what does the inner body do? It should increase our fusion rate for sure, and it should improve our alignment. It should reduce the slip and the slip angle, and it should allow us for indirect decompression of the foramen. So those are the key goals. And I'm not sure how much Charla has research in other fields besides medicine, but there's something called Occam's razor, which is the law of parsimony, which basically states that the simplest solution to any problem is the best solution. Okay, this comes up in mathematics where there's various different theorems, but the simplest is the best. And so I was always taught that from A to B, a straight line is the best way to get there. Okay, and I think we see with Charla that from A to B has multiple steps. And even looking at some of the MIS stuff shown this morning, I mean, there's 15 different pieces of equipment that you need to get to before you even get to the facet. So what about the value paradigm? We have to balance our outcomes against our costs. And this is a huge dilemma for us, and it's something that's going to drive what we do in every step of the way going forward. And our outcomes are different depending if it's the patient, the payer, or us. We have to look at short versus long term, and we have to obviously look at our complications and the risks. And this is a complex formula. But the bottom line is the better the outcomes, the better the value, especially if we can keep costs the same. Well, one of my mentors, and this is 15 years ago, said a TLIF is an easy operation to do poorly. And I think this holds today. There are a lot of steps. You got to work around the nerve roots. There can be tremendous bleeding. So you have to bear that in mind. And part of the reason why it's tough is because not just the number of steps, but when you add the complexity of an MIS approach, it puts into perspective the learning curve. And even in the best of hands, the learning curve is massive. It takes about 44 cases, in this case, first 90 cases on a single level by an experienced surgeon to reach the asymptote of the learning curve. And patients suffered. Patients had worse back pain in the study. They had worse leg pain. Their neurologic scores were worse. This was 2014. But what if you just say, all right, let's take the worldwide review of the learning curve for MIS. All the studies just looking at learning curve, all right? And they found durotomy, neurologic injury, need for conversion to open were typical. This is the conclusion, typical in the first 30 cases. And 90% of the learning curve happens after 40 cases. And the malpositioning of screws up to 13%. So the conclusion is the learning curve is shallow. It's not steep. Shallow is not actually what we want. and it's complex and it's very difficult to measure. So not all complications are created equal. And this is one of the shortcomings of the MIS literature, is they generally group all the complications into a certain number, percentage, but you got to break down the complications. So there's a cost to the complications. If you look at pooling data from multiple studies and you take 100% complication, what's the percentage of each of that total? Neurologic deficits in the MIS group, 20% of the total. Screw and cage malpositioning, 44% of the total complications. Now, infections are higher. You have an open surgery, you're going to have more of a seroma for sure. And blood transfusions are going to be higher. But when you're going to surgery for a procedure that's designed to decompress the neurologic elements, the last thing you want is an injury to that. And here's more data. If you look at a retrospective cohort, open versus MIS, obviously the MIS are going to have less length of stay. We've seen that, less blood loss. But the MIS patients had greater reoperations during that admission for nerve impingement. And of the durotomies, 7 of the 9 occurred in the open group. Now, they state that's not statistically significant because they didn't have enough patients. But that's something that you need to disclose to your patients beforehand. And now let's look at the best evidence. So forgetting all the retrospective data, let's just hone in on the 7 prospective randomized trials. Okay? MIS TLIF versus open, and I can just cut to the chase. The MIS patients, less blood loss and increased fluoro time, but no difference in VAS, oswestry, or length of stay. That's the best data we have, and we can go through the forest plots. So here's blood loss, statistically better for MIS. Here's fluoro, statistically better for open. VAS, the same. ODI, the same. Length of stay, the same. So what does the best evidence tell us? Well, number one, we know MIS is more complicated. It has a long, shallow learning curve, and the neurologic risks are high, especially in the first 40 cases. And the clinical outcomes are no better other than blood loss. 800 cc blood loss for a single level open is a high blood loss. I suspect that's patients who are having exposure of their transverse processes. What about implant costs? Definitely higher. What about use of BMP? Okay, 50% more BMP use in MIS cases. What about deformity correction? Better for open. Okay, this is a study just published in 2019, non-randomized, but they looked at various different parameters, slip percent, sacral slope, and the L1 to S1 distance, which is a measure of their sagittal plane. And the results, open were better for the slip reduction, change in slip angle, and the sagittal plane correction. Radiation exposure, the risks we really don't know, but we don't think they're trivial, especially when you look at musculoskeletal disorders and spine surgeons are much higher risk for these from lead wear. Do you tell your patients that they're going to have 3 to 10 times more fluoroscopy exposure during their case? Do you just tell them? Patient who's had a family history of breast cancer, you're going to have potentially 10 times more fluoro exposure during this case, and what would be their answer? What about teaching MIS techniques? There's no data on this. This is kind of like the blind leading the blind. All right, so when I think about the advantages of open, when I know I have an open case, it's just like it's a sunny day. I wake up, I'm in a good mood, okay, I can relax, I can enjoy my coffee, okay, I'm not upset when I get caught in a red light. There's no lead, there's no new instruments, there's no new steps, there's no bed clamps, there's no different lights, okay, there's no need for bringing navigation, there's not extra people in the operating room, okay, and the other advantage is unconstrained visibility. I like to see all of the neural elements. I like to be able to move my body in different positions so I can see the dura. I can be able to see where it's adherent. Your assistant can actually assist during the case, okay? And you can approach the L5 foramen from medial to lateral. Now, Jim has brought up some really good points, and I've learned some about going from lateral to medial, but you can still go lateral to medial in open cases, and I call that the backdoor technique. I think it works really well. And you can get all of L5, you can get to the inferior facet of L4, and you can use the same instruments on both sides, and you often get more bone graft. So in a case like this, would you rather approach this from lateral to medial? How do you know when you're at the dural edge when you're coming from lateral to medial? I'd much prefer to see the dura and be able to move medial to lateral. Okay, and then a really collapsed foramen, this is similar to the case that Jim proposed. To be able to see that and be able to trace the nerve root from medial to lateral, to me, is much more intuitive than going that lateral to medial. What are some other advantages? You know, triangulation is really important to get your right trajectory, but triangulation can be constrained when you have a tube. You can triangulate the tip of the tube, but you can't triangulate the skin exposure of that tube very well. I like to be able to palpate and visualize the pedicles, and then I can get ideal trajectory that's not constrained by the tube. Okay, and what about other advantages? It's more flexible. What if there's a conjoined nerve root? What about it if the epidural plexus is extensive and you have to do a lot of bipolar revision cases, and then handling a durotomy when that happens? The other piece about it is the intertransverse is readily accessible if needed. Other advantages, you can do a bilateral discectomy and bilateral TLIF if you'd like. You can visualize the threads when you're doing a reduction. I don't like to see those threads move at all because you can get screw pull out. And you can get absolute optimal placement of your inner body. Rod linkage there's no doubt rod linkage is simpler. And there's no pressure to add biologics. All right? You get copious bone graft, and you don't have to use a burr at all. You save all of the bone when you're using the keratins. So in conclusion, TLIF remains a tremendously challenging operation, even when done open. And MIS techniques, they just make it more challenging. There's no doubt about it. The outcomes are worse during the learning curve. The complications neurologically are greater. And the ethical issues are real, especially in the learning curve. Best evidence shows no clinical superiority. MIS costs are higher. And MIS, I believe, is less valuable when you look at it over the long haul. Open confers better visibility, versatility, and it's far easier to teach and learn. Thank you.
Thank you, Justin. Can we actually go back to Justin's last slide? Not the thank you, but the last one. And I'm going to ask Charla, because I think you deserve a rebuttal. I think this is probably the best slide to begin that process.
So I think, well, I haven't. So for rebuttal, I would say, if you go to the hospital and someone says you need a chole, who wants an open chole? Who wants a lap chole? If someone says you need your shoulders, rotator cuff repair, subacromial decompression, who wants an open rotator cuff repair? Who wants that done arthroscopically? So even though things are more technically challenging, doesn't make it mean that it's not better for patients. So I think that, yes, there is a learning curve, and a lot of us have experienced that learning curve, whether it's open or MIS, you know, you can do a lot of work in the lab, so you don't have to experiment on patients. And as far as teaching residents and fellows, I do believe that you should learn open techniques so you understand the anatomy, so you understand what you're feeling for and what you're working on when you're doing it minimally invasively. And the most important thing is what's better for patients. So yes, it may be technically challenging, but once you learn how to do the surgery, your patients are out of the hospital faster, and you're able to do what you need to do, which is the fusion, and they're having less pain and dysfunction and morbidity in the surgery. So yes, a shoulder scope does require a tower and a camera and fancier instruments, but most of us would agree that that's a better experience for patients than an open rotator cuff repair. So, you know, I'm not afraid of complex techniques, and I think that we should embrace new technology in a safe and effective manner, and then it will become standard of care so that patients are getting out of the hospital faster and back to their activities faster.
Can you just real quickly comment on how you minimize your ionizing radiation with your robot?
So we recently looked at this, and the radiation for percutaneous screws is very high. And there's a huge reduction in radiation when we use the robot, even if your patient has a preoperative CT. So taking that into account, the preoperative CT plus the intraoperative radiation is still significantly less than the normal amount of radiation that you do when you're doing percutaneous screws with intraoperative fluoroscopy. And everyone should find that very important. And so that was one of the main drivers for us to look into robotics and other avenues like less ray and things like that to just really decrease the amount of radiation. And it's both for the surgeon, for the operating team, and for the patient. And so I think that that's really important. And then the robot, at least the one that we use, you can use intraoperative fluoro screw planning, so you don't even have to get a preoperative CT. And that's what I prefer to use for patients, is just a couple x-ray shots in the operating room, plan their screws that way, and they don't even have to have a preoperative CT.
Yeah, we looked at a study not long ago at my institution doing MIS TLIFs. We use less than 10 seconds of fluoroscopy time through the whole case. I don't even wear lead any longer. I just step away and go behind a lead shield. So there are ways to minimize ionized radiation exposure. And I would suggest that that is something that we have to continue to work on, because I know some guys that still are using 2 to 3 minutes of fluoro doing an MIS TLIF, and they're watching their screws go in, under fluoro. They have, the foot control, and they're watching it. So we really have to educate those surgeons much better that you don't need to use that much ionizing radiation. So. Any questions?
Well, hold on, because I wanted a chance at a rebuttal too. Can you put up my rebuttal slide? It's you just keep going, scrolling down 2 more slides. Actually, go forward. Go forward. Keep going. I mean, we get a chance. 1 more. And then 1 more.
Oh.
All right. Okay, so Jim and Sig mentioned we were having a chance for rebuttal, so I was saving this study for the end. So this is a study recently published, okay, and it compares MIS posterior lateral fusion, okay, MIS TLIF, and a midlift, okay, and an open is the midlift technique. I mean, that's what I do. And one of the big problems with the literature on open TLIF is that it's a total apples to oranges comparison. The open group are selected and biased against, okay, because they're open, exposure to the transverse processes, bone graft laterally, inner body, okay, that's where you get the 800 cc blood loss. That's where you get the longer hospital stay. That's where you get the infections. But in open midline, okay, there is no learning curve. We have a study that's in press right now. The radiation exposure is minimal, okay, no one's wearing lead. And just like this study shows, clinical outcomes are outstanding, okay? Blood loss is less, OR time is less, and there's less tissue retraction, less tissue damage with the midline approach. So their conclusion from this study is the midlift is the least invasive, and I think that kind of seals the deal. If you can do all of this through a midline approach, minimal retractors, no new equipment, in less time with less blood loss, I don't even think there's a debate anymore.
Has anyone done a study where you just prospectively look at a bunch of cases and get into a cohort of surgeons, open versus minimally invasive, and look at decision planning? To me, that, especially with the direct lateral and percutaneous screws, some of the principles of classic deformity surgery has kind of gone by the wayside, and you see these long fusions to L5, but you can't get direct lateral at L5. And it'd be an interesting study to me to see the decision making, and is that altered? To me, you've got to figure out what you want to do first, and can you accomplish it minimally invasive or open equally, and see if that's affecting, because that's what some of the sense I get with some of the guys in our community is that the decision making goes sideways sometimes when they're trying to accomplish something for a minimally invasive surgery. It'd be a great kind of simple study of just presenting them, with 100 cases, and just get kind of the variance in terms of how certain things are.
So we looked at amount of central and foraminal stenosis between MIS and open cases at our institution. And turns out that there are a group of surgeons that are minimally invasive, so they're going to do an MIS TLIF. And there's a group of surgeons that will do open TLIF. And then there's the switch hitters. And those are the guys that will pick an open case if the central stenosis is greater, or they'll do an MIS case if the central stenosis is less. So I think that, to me, that's just choosing the surgery based on what you feel comfortable doing for the patient, which is totally appropriate and I think is great. You need to decide what the patient needs, what you can do in your hands reliably, and then apply that to the patients. And I work with one of the switch hitters a lot, and so he was talking to me about. And so we've been talking about, the contralateral decompression. Do we feel like that's getting enough of a decompression, or am I just kidding myself that angling the tube? And, a lot of times when I do that, I feel like, am I really doing anything here? Is the patient really gonna have improvement? And then after the surgery, they always feel better. Now, again, maybe because they're in the hospital and on Percocet. No, but seriously, you start to think about that, what am I actually accomplishing in this surgery? And a lot of times removing some of that bone and some of that soft tissue compression, patients feel a lot better. So that was really interesting at our institution that we're seeing surgeons who can do both types of surgeries really picking it based on what they need to accomplish for the patient, which is the most appropriate decision making I think that we should be doing.
Charlotte, I couldn't agree with you more. I think that last point is really critical, is trying to expand your skill set to be able to do all of this. And I can tell you over the course of my career, I've definitely evolved to virtually anything done as a decompression only I'm doing with a minimally invasive approach, without a tube, but I'm definitely being much more minimally invasive about it. And in my hands, when I'm trying to get a good fusion, I just feel like I get a much better graft preparation and fusion with an open technique. And the one question I want to bring up that wasn't brought up is, if there is some kyphosis in a degenerative spondy, the ability to really get a reduction, how are you taking out the facet joints? Because Coy pointed out that the MIS TLIF is not kyphogenic. But having said that, certainly my ability to get restoration of sagittal alignment is a lot better if I truly do a posterior facet resection. How are you doing that with the tube? And are you doing that as well with the tube than you would be doing open?
So for the MIS TLIF, every case I'm going to drop a tube on the contralateral facet and do a facet preparation for fusion. So in cases that I need more compression posteriorly to restore the lordosis, you can just take that facet down completely so that you get more motion there. And then I think those are the cases where you might want to consider using an expandable interbody device to help jack up the front. Sometimes, depending on your placement of the screws, so if you're trying to avoid the facet joint at the level above, you have lower starting screws, say at 4, and then they're really close to 5. So just compressing those tulip heads together may not give you enough lordosis. So those are the cases that I'm more concerned about, but I think the expandable interbodies can really help you with that if you're concerned.
And let me add one more thing. At least in my experience, every case I do, I use the Axis Jackson frame, which really allows you to, once you do your interbody work, you can really kyphose or lordose the spine. So we typically kyphose the spine during the decompression, the interbody work, and then lordose it to lock it down. And we actually have a study out, or not out, but almost out, that shows just by doing that, we do intraoperative x-rays, just by doing that you can get up to 5 degrees of additional lordosis with using these dynamic frames. So
That's a good point. I like them a lot
The other
too.
thing we found is that even if we do get a lot of for these lumbar degenerative cases, if we get a lot of segmental lordosis, say at 4 or 5, we see reciprocal loss of lordosis at the levels above. So you want to think about the harmony of the spine. And also, patients have a certain alignment that they want to live in. So if you're not doing a deformity correction, sometimes I think we're so focused on lordosis at one segment that we kind of forget that the rest of the spine is moving and flexible, and your overall lordosis may not have changed as much. And we saw that in our review of looking at single-level fusion.
Yeah, just one final point. I think with the TLIF, no question with the tube, you do a really good job taking out the facet. I think a really big part of the decompression there is taking out the superior articular facet, a level below, so the L5 superior articular facet, especially if you're going to try and create lordosis. But Jim, you had mentioned trying to preserve that interspinous ligament, and I think a lot of times that's also a big barrier to creating lordosis. So when you take down the interspinous ligament, and then does that take away all the advantage of the tube?
So to truly take that down and take the spinous process, it's very difficult to do MIS because essentially you're going from the fascia all the way down. So if that's a big component, that's what's going to limit you. There's no doubt. Versus if you're doing it open and you do a true, laminectomy with the resection of the spinous process, I think you probably get a couple more degrees of lordosis doing that.
And then I just have a question for the audience. I've noticed, degen spondy is higher rate in women, but in general, women's spines remain flexible and mobile a little bit longer than men. And I think in like a 70-year-old patient with multi-level degeneration, if I'm not as concerned about changing the alignment because men tend to get stiffer than women, but that's not scientific. That's just sort of my overall what I see with patients. Does anyone else see that women are a little more flexible longer and men kind of just stiffen up and stenose?
I think so as well, especially when you're talking about like one-level degenerative respondees. Typically an elderly man, it is pretty rigid, but women, they can be extraordinarily dynamically unstable. So I've seen that anecdotally.
Yeah, I agree for sure, and I think that's why women have a higher risk for degenerative spondylosis to begin with. Yeah, they're more.
And their facet joint orientation, all those other things that we know. But thank you so much, you two. That was a lot of fun.
Good stuff.
We actually have